Hello, my name is Julia Fauski, and I will be discussing today OB emergencies in the air medical environment. In order to really understand what's going on with our patients, we need to understand the normal anatomy and physiology changes that happen during pregnancy, the assessment involved, flight concerns, and high-risk care, as well as OB emergencies. We're never called when they're healthy. We're only called when they are sick, when there's things going wrong. So in order to really fully understand what's going on when things are going wrong, we're going to discuss the normal changes first. Some physiological changes involve all of these systems listed here, and then some. We're only going to touch the tip of the iceberg. So in order to get all the information in that I need to get in such a short period of time, I am going to be moving a little bit fast. So I want to throw this out there. I'm always available for questions if you have any questions, as is your clinical educator. And so if there's something that maybe I move too fast on or that you don't fully understand, I'm always available. Feel free to contact me or your clinical educator, and we'll be glad to clarify anything for you that maybe that I didn't get across very well. So some of the changes, of course, we'll start with reproductive system. Some of the reproductive changes, the uterus increases by 20 times. The cervix softens, increased mucus production. Vaginal changes include increased vascularity and hypertrophy. Breasts also increased vascularity and hypertrophy and increased pigmentation. Some specialized structures of pregnancy that only come around during pregnancy include the placenta, the umbilical cord, the amniotic sac, and the amniotic fluid. The placenta, of course, produces hormones and provides the fetus with oxygen and nutrients and takes away waste. And the umbilical cord is really rather cool in that there's two arteries and one vein, and it's kind of backwards. Blood flows from the fetus to the placenta by way of two umbilical arteries, and that carries deoxygenated blood. And oxygenated blood returns to the fetus by way of the umbilical vein. Fetal circulation is a little different in that there's a couple of shunts involved, and they include the ductus arteriosus and the foramen ovale. The foramen ovale allows blood to go directly into the left atrium from the right atrium, and the ductus arteriosus allows blood to bypass the pulmonary circulation, as the fetus obviously isn't breathing air, so blood does not really need to circulate into the lungs at this point. That does close up at birth, usually. The amniotic sac is a fluid-filled cavity surrounding and protecting the fetus, and the fluid fills that sac, and it is composed of fetal urine, secretions from the respiratory tract, skin, and amniotic membranes. And the fluid accumulates rapidly during pregnancy and ends at term with approximately a liter or so, give or take. Of course, we all know fetal growth and development starts with fertilization, which occurs in the fallopian tubes when the head of the sperm penetrates the mature ovum. And here you have a picture of a human embryo and fetus at 35 days. As you can see, there's already eyes and limb buds, and there's already a heart, and it is already beating. For the first 8 weeks, it's called the embryo. Weeks 6, 7, and 8, the heart is beating, kidneys producing urine, and the size is about 3.2 inches at 8 weeks. 9 to 14 weeks, we go ahead and start calling this thing a fetus, and fetal heart tones are audible with a Doppler. And at this point, the fetus is most vulnerable to toxins. Some demands increase. Mom may not even know she's pregnant at this point, but she is actually needing more folic acid and some other things that she probably doesn't even know she needs at this point. And so the fetus is extremely vulnerable at this time. 17 to 20 weeks, the fetus is approximately 8 inches, weighs less than a pound. Fetal heart rate is audible with a stethoscope. A mother is able to feel movement. Hair, eyebrows, and eyelashes are present. 20 plus weeks, size starts at about 11.3 inches at 20 weeks, weight's approximately a pound. There's increased fetal activity, and they begin respiratory movement. At 24 weeks, there's more and more activity, of course. Fetus is approximately 28 centimeters and 1.5 pounds. This baby has reached the age of viability at about 24 weeks. And so if this baby were to be born at this time, they would go ahead and take it to the NICU and do everything they could to preserve life. At 28 weeks, the eyes will open and close. Weight's about 2 to 3 pounds, and surfactant is being formed. And at 32 weeks, the bones are fully developed and fingernails and toenails are present. Some cardiovascular changes that happen to mom at this point involve the heart increases from 10 to 15%, stroke volume is increased, cardiac output is increased. I think that's supposed to say heart rate is increased. Anyway, cardiac output is increased 25 to 30% and pumps approximately 1.5 liters a minute. Catecholamines are increased. You may hear S3, soft systolic murmur at this time, and lab work will show decreased hemoglobin and hematocrit. Mostly it's dilutional. Total peripheral resistance is decreased. And remember, blood pressure equals cardiac output times total peripheral resistance. So blood pressure may be decreased at this time. Blood volume increases by up to 50%. So volume is 23 to 30% plasma, meaning that H&H will appear lower dilutionally. As hemodynamic changes occur, it does cause changes in blood pressure, which is usually lower. And of course, an increased blood pressure would indicate possible problems at this time. And a key element here, remembering that cardiac output equals heart rate times stroke volume. So that just indicates, you know, everything's increasing, your metabolic needs are increasing, and so that's putting a lot of extra oxygen consumption needs, extra stress on mom. Mom's also in a hypercoagulable state, meaning she is predisposed to DVTs and other clot-related conditions. Clotting factors change, also predisposing her to DIC. Some respiratory changes that occur involve respiratory rate increase and tidal volume increase. Minute volume is increased. PCO2 is decreased to about 30 millimeters of mercury. Arterial pH is increased to 7.45 or so, which means she's actually in compensated respiratory alkalosis, and that's quite normal. Some other respiratory changes include increase in oxygen demands, 20% increase in oxygen consumption, 40% increase in tidal volume, yet the room for expansion is decreased as pregnancy progresses. So the diaphragm is pushed upward, and so the increased work of breathing can be a problem. And of course, there's less room for the diaphragm, and so this leads to dyspnea even after small amounts of exertion, say climbing some stairs or something. Mom's probably going to be out of breath by the time she gets to the top if she's, in her later weeks. That being said, all pregnant patients should be put on oxygen. If they're set at 98%, that's okay. She still needs oxygen. You can look up, we actually have an SMP that gives a calculation for the correct FiO2 that should be delivered at this time. And really, you can't go wrong with high flow oxygen to every pregnant mom. The altitude changes increase her oxygen demand. And so she may be compensating, keeping her sat at 98%, but that's actually harder for her to do. And it's actually causing more work for her to maintain and compensate for that extra work. So moving on, some renal changes include increased renal blood flow, Her GFR is going to be increased. Her BUN and creatinine are going to decrease, and her renal pharmacologic clearance will be increased. She is more likely to have glucose spilling into her urine. Bladder is going to be displaced anteriorly and superiorly, so that increases the likelihood of rupture during trauma. Urinary frequency is common, especially in the first trimester, while baby is still a pelvic organ. Protein, glucose, and white blood cells in her urine indicate potential problems. Some GI changes. Her gums will be swollen and soft, and they may bleed when she's brushing her teeth. Her GI tract, the smooth muscle will relax. She'll have prolonged emptying, constipation, hemorrhoids, heartburn, upward displacement of her stomach, and her appetite will increase. Peristalsis will slow. She may need to eat smaller meals more frequently because her stomach's not going to be allowed to expand as much as normal. Other GI changes include increased probability of gallstone formation due to delayed gallbladder contraction and increased production of lipids and cholesterol. Her liver enzymes will increase slightly, and so this is going to be key when you're trying to decipher preeclampsia versus hepatitis versus HELLP syndrome. And so remember that. Some musculoskeletal changes include her pelvic joints and other joints, of course, will loosen, and they'll cause a waddling gait. It also might cause her to be more clumsy because she's just not used to all these loosey-goosey joints, and she's also trying to accommodate for the increased anterior growth, and her center of gravity is going to be off. And so she'll have increased complaints of low back pain. She also may have some round ligament pain in the front, all the way around to the back due to her growing abdomen. Her integumentary system will undergo hyperpigmentation, melasma, linea nigra, nipples will darken, moles will darken, increased freckles. These things should go away after pregnancy. May take a while, but they should go away. Some connective tissue issues. Her connective tissue will be more fragile, so she'll be more prone to stretch marks. She'll have increased hair growth, edema, spider angiomas, and palmaroerythema. Her metabolic changes include protein, carb, and mineral and iron demands will increase. Her water requirement will increase in order to supply the fetus, the placenta, and her amniotic fluid, and to expand her maternal blood volume. Normal weight gain will be 25 to 35 pounds. Most pregnant women don't increase their fluid intake as much as they should, so it increases the likelihood that she's going to be dehydrated or that she might have a drop in blood pressure when she stands up too fast, and so on and so forth. Some endocrine changes include many hormonal changes, as many of you may know already. Her ovaries secreting estrogen and progesterone at a larger volume, pancreas with increased insulin production, pituitary glands will increase the production and secretion of prolactin and oxytocin. Care of the OB patient includes, of course, your ABCs and scene safety always, all the time for every patient. You'll want to obtain vital signs, including fetal heart tones, deep tendon reflexes, and, of course, her temperature. Large bore IVs with LRNS, high flow oxygen at 10 to 12 liters. You'll want to position her on her left or right side, and rapid transport to appropriate hospital. And you'll hear this a lot. This will be a recurring theme for the next hour or so. What you're going to want to know pre-transport includes her history, both her OB history and her non-pregnancy related history. You can use a sample mnemonic to remember some things that you're going to need to know before you leave with that patient, if at all possible. S is signs and symptoms. A stands for allergies. M for medications. Does she take any regular medications? Has she been given anything during this stay? P for past medical history, both OB and non-OB related. L for last oral intake, if you can get it. E for the events leading up to the present illness or issue that's going on with her. For an assessment, you're going to want to do a basic head to toe like you would do on everybody else, except you're going to include a few extra things, some OB specific things. You're also going to definitely want to check her reflexes. If there's any chance you're going to be giving MAG, you're going to need a baseline. So also palpate the abdomen and check some fetal heart tones and get a rhythm strip if you can. Now is a great time to put your patient on a fetal monitor, which you all have access to. Usually, and any OB history or lack thereof. Has she had prenatal care or not? Has she had any other issues going on? When was her last normal menstrual period? Has she been having abdominal pain? If so, how does it feel? When did it start? Is it strong? Does it stab, ache? You know, the location, quality of it. Is she bleeding at all, or is there any discharge? And is she sexually active? Furthermore, is there a possibility that she might be pregnant and not know it, or not be recognizing it, or admitting it? Has she had any missed periods? Has she been nauseous or vomiting, increased urinary frequency, breast enlargement, or vaginal discharge? If she is pregnant, has she had children before in the past? Has she been pregnant before in the past? And again, you'll need to know the last menstrual period, the first day of her last period, so that you can kind of guesstimate her expected date of confinement or due date. And in which case you can look at the first day of her last menstrual period, subtract 3 months and add 7 days. So for instance, December 9th of 2016 was the first day of her last period that she can remember. Subtract 3 months, you're back to September. Add 7 days. So 7 days after 9 is 16. So her due date should be about September 16th of 2017. There's other ways to determine the gestational age as well. You can palpate the fetal movement, and if you can feel fetal movement, she's at least 20 weeks. You can measure her fundal height. You can also use the will or the formula, which we just discussed. The way to measure her fundus would be you start at the pubic symphysis and you take your tape measure all the way to the top of her fundus, and that many centimeters should equal about how many weeks pregnant she is. You can also use a rule here, 12, 16, or 20 weeks. 20 weeks should be fundal height right about the umbilicus. Or as you can see on the picture here, and multiple pictures here actually, it can kind of tell you about how many weeks she is. And as we sit here with this picture on the screen, I want to go ahead and throw a disclaimer out there. There's probably going to be some graphic pictures here. Well, not probably, there will be graphic pictures. And so we are very blessed to have had people that would allow cameras in their most vulnerable and intimate moments of their life. And so please be respectful of that and be thankful that they are sacrificing this for your education and for mine. So that's really awesome. Thank you. Moving on, calculating her EDC, you'll definitely need to know her last menstrual period. The first day is where you always go off of. The EDC, or the estimated date of confinement, or her due date, can be calculated by the formula that we just discussed. Some other assessment that you're going to need to know, you're going to need her vital signs. Is she hypertensive or hypotensive? You may want to do a tilt test, orthostatic blood pressures if blood loss is suspected. Be careful though, because as soon as they stand up, they may fall right back down. As soon as they sit up, they may feel like they want to pass out, or they may actually pass out. Like we just discussed, most women aren't drinking enough water, and their consumption or their demands actually increase. Their consumption does not increase, especially if they've been nauseous or vomiting. So they're already a little dehydrated, and so their fluid status is already kind of behind the bar. So just be very careful when you stand them up, especially if you do so quickly. They may have some edema, particularly of their face and hands. Abdominal exam will include fetal heart tones and the fundal height, uterine tenderness or fetal position. Can you tell that right now. A pelvic exam. Is she dilated at all or effaced? What's the station? Do we have any presenting parts? This, by the way, is never done in the presence of acute vaginal bleeding. You really don't want to do a pelvic exam at that point. And at any point, you don't really want to be the one to do a pelvic exam unless you are the last resort. You always want to have the provider do the pelvic exam if at all possible. And sometimes you may actually want to have them do it while you're standing right there, because there may or may not have been times in the past when a provider just wants this patient out of their facility. And so they'll tell you she's dilated to a 2 or a 3, but they haven't checked her in 5 hours. So you may, if you can appropriately do so, ask them to go ahead and just do another final exam if it's appropriate, if, membranes aren't ruptured and you're not increasing the chances of infection, or if there's no vaginal bleeding, then it's absolutely appropriate to ask if they can do another vaginal exam if it's been a little while since they've done one. If you end up being the one having to do the vaginal exam, always make sure you have someone else in the room with you when you do it, and always make sure you respect her privacy when you do that as well. Pre-transport, some other things you're going to want to know: gravida, peristatus, multiple gestations. How many weeks is she? When's her due date? Has this been confirmed by ultrasound? Is it intrauterine or not? When was her last menstrual period? Is she having contractions? When did they start? How often are they? When you time contractions, you're timing from the beginning of one contraction to the beginning of the next contraction. A lot of people don't know that, so you may have to do some education, and you may have to sit there in the room and time a few contractions before you can really decide whether this flight is appropriate for you or not. Is she dilated at all? What is her weight? Has she gained or lost weight recently? Does she even know? What are her vital signs? And what's her temperature? And what's the fetal heart rate? And what's the pattern? Are there decels? Are they early? Are they late? Is there good variability? Some current medications that she might be on, you're going to want to know. Is she on any IVs? Has she had anything already, terbutaline or breathing? Has she been given anything at all? What are her lab values? And what's her glucose level? Do you have a copy of her medical and surgical history, if it's available? What's her past OB history? And has she had any prenatal care? Is there vaginal bleeding? And if so, how many pads have been soaked in an hour? How long since it started? Have they been weighing pads? Or you can weigh the pads. It's usually about 1 gram equals 10 cc's. So if you don't want to get into all that, you can just save the pads and let them weigh them at the receiving facility. And but that is key to know if she's bleeding a whole lot or just a little or kind of. That's definitely important information. Some vocabulary that you're going to need to be familiar with is the gravida status. How many times has she been pregnant total? Her peristatus, how many babies has she delivered? So if she's been pregnant 5 times, but she only has 3 babies at home, that makes her a gravida 5, para 3. And if she's a prima gravida, she's a woman who's pregnant for the first time. Multigravida, she's had 1 or more previous pregnancies. Multiparous, she's actually delivered more than 1, or she is pregnant with more than 1 fetus. A nulliparous is a woman who's never given birth to a viable or live infant. And an abortion is any miscarriage or loss of products of conception, whether intentional or unintentional or otherwise, before 28 weeks. So if she had a miscarriage, they still call it an abortion. And you may have to explain that to her when you're given a report or something. She may look at you like, you completely offended her because you said she's had an abortion in the past, when really she's just had a miscarriage. So there may be some education that you might need to do so that we don't completely offend all of our patients. How can you evaluate fetal well-being in the field? Well, like this. You can ask if she feels the baby move, and how often, how many times an hour has she felt the baby move, if she's even counting. And can you feel the baby move when you're palpating her abdomen? Can you auscultate fetal heart tones, which normal range would be between 120 and 160-ish. You can use a Doppler. You can use your fetal monitoring devices and ultrasound, of course. Some air medical concerns involve you being well aware that you have two patients, not just one, and maybe three, maybe four, depending on how many fetuses she has inside of her. She's not your only patient. There's definitely more than one there. There's definitely an effect of altitude on the mother and the fetus that you need to be aware of, and they need a trained team, and there are some transport concerns that you need to know. Backing up just for a second on the trained team part, I would highly encourage you to, if you haven't already, go ahead and take a high-risk OB course or an OB stat course, because in no way does this little orientation, this is just a touch of the iceberg, in no way does this really cover all the things that need to be covered to really adequately care for this patient and feel 100% comfortable doing so. So if you get the opportunity, definitely jump on it. Some patient altitude patho will discuss hypoxia, gas expansion, and G-forces. At higher altitudes, the oxygen available to the mom decreases, and there's a proportional drop in the oxygen transported across the placenta to the fetus. The fetus does have many mechanisms to compensate. Our bodies are absolutely amazing, and there's all kinds of compensatory mechanisms that are going to go into effect. But one thing you need to remember is that your mom isn't completely healthy here. They wouldn't be calling you to transport her if she was 100% healthy. So your baby's already behind a little bit. So here in a minute, you'll see that we say the baby can go 30 minutes, but in reality, your mom's not 100% healthy. So that compensatory mechanism is already being used up. The fetus does have the ability to redistribute the blood flow to vital organs, and the fetal blood does have a greater number of RBCs than adult blood, so it has an increased oxygen carrying capacity. The fetal hemoglobin also has a greater affinity for oxygen, so that's all great and everything. When the fetal PaO2 drops, the fetal oxygen dissociation curve shifts left. So this allows a saturation of fetal hemoglobin decreasing the total oxygen consumption over a period of time. So that's all great. The effect of hypoxia on the fetus depends on several factors, though, and these include the maternal status, utero-placental function, and duration of hypoxic episode. If the mother's status is not severely compromised and the utero-placental unit is healthy, the fetus may tolerate 30 minutes of hypoxia. As you well know, our moms are not usually 100% healthy, or they wouldn't be calling us. So you can just go ahead and commit to memory that 30 minutes is not for you. That's for a perfectly healthy mom and in an acute situation. So some conditions that worsen hypoxia include, but are not limited to, placenta abruptio, maternal hemorrhage, preeclampsia, and eclampsia. When problems arise, this is when we get called. You may have a mom in preterm labor, premature rupture of membranes, pregnancy-induced hypertension, or gestational hypertension. That's a hotly debated subject as to what we call that now, but moving on. Preeclampsia or eclampsia, HELP syndrome, abruptio placentae, placenta previa, postpartum hemorrhage, or precipitate labor. Gas expansion, definitely worth discussing. Pressure from gas expansion in the bowel causes the uterus to begin or increase contractions. As gas expands around the breast tissue, the breast may begin to leak, which also stimulates the release of oxytocin. The preeclamptic patient is already at risk for pulmonary edema due to increased permeability of the vessel walls. So increased altitude can cause pulmonary edema and hypoxia. And like I said, your mom always should be on oxygen. Even if she's fat and fine, she should still be on oxygen. The G-forces may worsen pulmonary edema in the preeclamptic patient because acceleration increases ventilation difference already present. So you may be in a pressurized cabin, but you've got these G-forces affecting your mom. And so that's working against the fetus as well. If the cervix is dilated, or if the bag of water is bulging, G-forces can increase the dilation or rupture the bag of waters. G-forces applied in a particular direction can increase the pressure of the fetus against the cervix. So you may want to use appropriate patient positioning, and keep in mind that if your mom's feet are toward the back of the plane and you're taking off at 100, 200 miles an hour, all that pressure is now putting that bulging bag of waters directly on her cervix. And so definitely something to keep in mind when you're positioning your patient. And so sorry. A word on mission limitations. SOP number 15 gives guidelines on which OB transports we can take and which we won't take. And it states, Apollo MedFlight will only transport high-risk OB patients under certain circumstances. Apollo MedFlight defines high-risk OB as a transport that is directly related to a pregnancy that may endanger the mother or fetus of a gestational age greater than 20 weeks. This does not include pre-existing conditions or trauma in the pregnant patient. Apollo MedFlight will only transport high-risk OB patients with the following conditions. Pregnancy 20 weeks or less in gestation when the health of the mother requires transport. This technically is not considered high-risk OB due to being outside of the definition of high-risk OB, but listed for clarity for communication and clinical staff decision-making. Full term, 37 weeks or greater, uncomplicated pregnancy without fetal distress, dilated 4 centimeters or less, and that is being transported due to a lack of services or specialists at the sending facility. We'll also take preterm 36 weeks or less, but 21 weeks or greater without complications other than the complication of preterm labor itself, without fetal distress, dilated 3 centimeters or less, and that is controlled with tocolytics or other means. Apollo MedFlight defines controlled as stopping or slowing cervical changes produced by contractions, decreased duration of contractions, contractions become irregular and greater than 10 minutes apart from each other, or decrease in intensity of contractions as noted on patient exam and or via fetal heart rate monitor or fetal heart monitor. The following OB complications are acceptable for Apollo MedFlight to transport. Premature rupture of membranes, dilated 4 centimeters or less, without fetal distress, and without contractions or with contractions that are controlled with tocolytics or by other means. Pregnancy-induced hypertension, including preeclampsia or eclampsia patients without fetal distress. Special consideration should be given to severe preeclampsia patients prior to transporting to avoid seizure activity en route. Apollo MedFlight defines preeclampsia as a blood pressure greater than 140 systolic or 90 diastolic, or a 30 millimeter of mercury rise in systolic pressure or 15 rise in diastolic above the baseline after the 20th week. This may be accompanied with proteinuria or edema. This is also when it's really important to have a baseline. Apollo MedFlight will not transport infants weighing 5 kilos or less that require an isolette or that require specialized ventilator support. So 5 kilos is our minimum weight for a baby already born. Please note that OCC does have an OB intake checklist and a flow chart that they follow prior to making contact with the flight crew to help determine the appropriateness of the flight. See your SOPs and SMPs posted in an EMS manager for further clarification on this. I think it's SMP 15, and it's listed right there, the flow sheet, what they ask the hospital, and if mom's dilated to 4, has this or that going on. They may send a flight crew out there to reassess the situation and try to slow or stop contractions, but they haven't technically accepted that flight until mom meets the criteria listed already. SMP 253, general obstetrical transports, is listed here. Of course, you're going to refer to your mission limitations, and then your initial medical care on every patient, and then your history, which we've already discussed. You're going to need to get these things on every OB patient that you have if these things are available. You're also going to want to determine if she's dilated or not. A digital or sterile speculum prior to departure by personnel trained in the procedure, or document last exam prior to arrival unless contraindicated. Assess the fetal monitor tracings. decide whether there's variable deceleration, early decels, late decels. If there are late decels, this must be treated promptly. You cannot take that patient until you either fix that or call medical control and get further direction. That is a sign of fetal distress. It's an ominous sign that you do not want to put that mom and that baby in the air with you while mom's still having late decels. Bradycardia, which is defined as the fetal heart rate less than 120 for greater than 10 minutes. This is usually associated with cord compression, but it still must be treated promptly, and you must inform medical control prior to departure from referral agency. Tachycardia or fetal heart rate greater than 160 for greater than 10 minutes, usually associated with infection. You can attempt to alleviate causes prior to transport. You can give fluids to bring down a fever. You can give antibiotics if ordered by the sending facility. Some of these things will help right away. Interventions for fetal stress or distress, evaluation and treatment of suspected causes, a reposition to her left side or her right side if that's better. You can put her in Trendelenburg or knee chest in the presence of fetal distress. You can give her oxygen at 100%. You can give her IV fluids, continually reevaluate and intervene until fetal distress is resolved. Consider delivery at outlying facility if transport time is lengthy or unexpected delays. You can stay and assist with that. In fact, you are encouraged to stay and assist with that. Continue to Doppler fetal heart tones every 15 minutes, and some protocols actually state 15 minutes depending on what's going on, or every 10 minutes depending on what's going on with the baby. So commit that to memory. Secure some other patient care you're going to want to know. You're going to want to secure the straps low on her pelvis. Now, obviously, you don't want to go over her abdomen with the abdominal straps. If her membranes are bulging, you're going to consider placing her feet first into the aircraft to decrease the pressure on the cervix before the takeoff. You may want to clarify that with your chiefs or a clinical educator. That would be something that is not in our regular line of care, but definitely something worth considering if mom's got a bulging bag and you've got no other option but to put her in the plane and take her. Oxygen, of course, and medications as needed. Know what we carry and know how to utilize it, because you can't really do much good if you're not using all the tools in your bag, and if you don't know exactly what you have, then it doesn't do you a whole lot of good to have it. You're going to want to maintain mom's temperature, maintain her oxygenation, administer labor suppressing drugs as needed, such as MAG or terbutaline. Preparation for transport. Get report from the sending facility if it's an inter-facility and if they have something for you. Do a thorough assessment. Obtain her vital signs, including her temperature, fetal heart tones, and DTRs. Change over any drips and recheck your rates. Apply all the needed monitors that you need. Grab your necessary paperwork, your history and physical, your nurse's notes, your AOB, and your CMN. Get your face sheet, your state forms. If they're in the state of Oklahoma, they have an extra form. Texas doesn't at this point in time. Get any records that she may have and any lab work. Do a flight briefing with your mom and any rider that may be coming. And of course, if she's over 20 weeks or showing any kind of abdomen at all, if she looks even slightly pregnant, go ahead and put her on her left side or her right side if that's more comfortable. Some special patient considerations include hypertensive patients. Go ahead and consider using some eye protection and take some earplugs. Maybe take a towel or a washcloth that you can just put over their eyes to decrease their stimulation. That will help a little bit. And preterm labor patients, you want to limit their movement, consider sedatives if possible, and consider antiemetics if needed. During transport, you've got to stay calm and recognize your limitations, and don't be afraid to get on the sat phone and call medical control or your receiving physician if you need to. Circulation, airway, breathing, oxygen therapy will go a long way for a variety of issues. So always put your mom on oxygen, even if she's not broken there, go ahead and put her on oxygen anyway, just to decrease the work that and the stress that her body's under. Always put her in her left lateral recumbent position to avoid pinching the inferior vena cava. You don't want to slow or stop the blood flow back to the right side of the heart. If you decrease her preload, her blood pressure will drop, and that will decrease the blood flow and the oxygen delivery to the baby. It will also take some of the pressure off her cervix, so that will be helpful. Monitor vital signs every 5 to 15 minutes and fetal heart tones every 10 to 15 minutes. And of course, her contractions, intensity, duration, and frequency. You want to know what you have, and you want to know where to get it, and you want to know how to use it. So go ahead and familiarize yourself with the tools in your bag and where they're kept and how to mix the drips that you might need. Go ahead and just, when you know you're going on an OB patient, review, look it up right quick on your way, and make sure that you go in prepared so that you feel more comfortable and your mom will feel more comfortable, and your mom will have a better outcome if you are able to utilize the tools that you have been given to help her. So preterm labor, 8 to 10% of all gestations and preterm labor, 80% of neonatal mortality, and 50% child handicaps are due to preterm labor. The risk of recurrent preterm birth after 1, 2, and 3 consecutive preterm births may be increased to approximately 15, 30, and 45% respectively. Uterine contractions with cervical change after 20 weeks and prior to 37 weeks is what defines preterm labor. And for prevention in a patient with a history, some may have a cerclage or a suture that is there to reinforce an incompetent cervix. Cervical length is a strong predictor of delivery, so less than 2.5 centimeters is a strong predictor of delivery. Some predisposing factors for preterm labor. Previous preterm labor is your biggest risk. Multiple gestations, polyhydramnios or too much amniotic fluid, the uterine anomaly or abdominal surgery during pregnancy, cervical incompetence, poor oral hygiene for whatever reason, infection, and cardiovascular and renal disease. Minor risks include febrile illness, bleeding after 12 weeks, a history of pyelonephritis, a smoker, or a previous second trimester abortion will all increase your risk of preterm labor. Infants born at 23 weeks have more than a 90% chance of dying. Babies born at 26 weeks change the odds to 90% chance of survival if given the proper care. This accounts for 50 to 75% of perinatal morbidity and mortality if delivery occurs. And I apologize for reading directly off the slides, but my auditory and visual learners may appreciate it. I have a hard time personally listening to different words than what I'm reading. So I feel it is necessary to read off the slides, and I try to put as much information on the slides as I can so that if you need to print it out and take it with you, you have that information, and it's just more helpful that way. So moving on. Other precipitating factors include a urinary tract infection, dehydration, trauma, of course, substance abuse, and intercourse, which increases the oxytocin production and release, which increases contractions, which precipitates preterm labor. So signs and symptoms of preterm labor include low back pain or pressure, increased vaginal discharge, leaking fluid, loose stools, spotting, menstrual-like cramps. Of course, your uterus is contracting when you're having menstrual cramps, and that's exactly what it's doing when you're in labor. So it's going to feel like menstrual cramps, and your abdomen or her abdomen will be balling up. Some therapeutic interventions would include bed rest, IV hydration, beta mimetics, mag sulfate, calcium channel blockers, and indomethacin, which may be given at your sending facility. Mag sulfate may be used to halt contractions. It's a central nervous system depressant that prevents reflux of calcium into the myometrial cells, thereby keeping the uterus relaxed. Contraindications include severe abdominal pain of unknown origin, oliguria or no urine. You're going to want to definitely measure urine output closely and have a Foley catheter Mag level increased over 7. If her mag is over 7, stop the drip. Decreased blood pressure, because the mag is obviously not going to help with that. It's a CNS depressant, so it's going to drop her pressure. So if she already has a decreased pressure, then you don't want to give it. Decreased deep tendon reflexes. That's a sign that she does not need the mag. Decreased respiratory rate, and of course, cardiac arrhythmias all will cause, the mag will cause bigger problems. When you do need to give mag, you'll give a bolus dose of 4 to 6 grams over 20 to 30 minutes. Usually it's in 50 cc's of LR, and a maintenance dose of 2 to 5 grams per hour. And the way they usually mix that is 40 grams in a liter of LR, and it's usually given at about 50 milliliters an hour. Give or take. You'll want to follow your sending physician's orders, or if they don't give orders, if you're starting it in flight, then the protocol would just be 2 to 5 grams per hour, and you can kind of use your judgment as to whether you want to start high or start low on that. Always remember to check your deep tendon reflexes. Get a baseline before you start the mag drip, and then continually check it and document it throughout the flight. Therapeutic levels of mag are 4 to 7. Definitely stop the infusion if you see her lab work says that her mag is over 11 or over 7. I'm sorry, over 7. If you lose deep tendon reflexes, or if her respiratory rate decreases to less than 12 a minute, definitely stop the mag. Some adverse effects on mom, of course: drowsiness, flushing, warmth, nausea, headache, slurred speech, blurred vision, and central nervous system depression with a respiratory rate less than 12, hyporeflexia, oliguria, cardiac arrhythmias, and cardiac arrest. Some of these things, she may feel warm, flushing, she may get a headache and a little nausea when you're given the bolus. As soon as you stop the bolus or slow the bolus down, those things should alleviate. If that doesn't stop, then that might be an indication that she's had too much, or she's getting too much, or you need to back off a little bit on it. Some fetal adverse effects: hypotonia and bradycardia. If you are monitoring fetal heart tones and your baby becomes bradycardic, then absolutely stop the mag. The antidote, you may need to give an antidote. The antidote, first choice would be calcium gluconate, 1 gram over 3 minutes, or calcium chloride would be a second choice at 0.5 grams over 10 minutes. Really slow. You may wish to give terbutaline. It's a beta-2 adrenergic receptor agonist that causes smooth muscle relaxation. Contraindications include severe gestational hypertension or cardiac disease. If being administered as a drip, expect it to be administered for 12 to 24 hours after contractions have ceased. Then she'll likely be put on an oral dose until the fetal maturation has progressed. Terbutaline is a beta mimetic, and the dosage for preterm labor is always sub-Q, 0.25 milligrams every 15 minutes for 3 doses. You do have that in your bags. Usually, as long as your bags are stocked, then you should be able to carry that with you. You're going to monitor for tachycardia, hypotension, hyperglycemia, and chest pain. Some adverse effects on mom: tachycardia, diarrhea, nervousness, tremors, nausea, vomiting, headache, hyper or hypoglycemia, hypokalemia, pulmonary edema. Fetal adverse effects include tachycardia, hypoxia, hypoglycemia, and hypocalcemia. Contraindications for sure would include mom's pulse being over 120, poorly controlled insulin-dependent diabetes, because it's going to cause their blood sugar to be wacky, severe chronic hypertension, cardiac conditions, and active hemorrhage. The antidote is propranolol, 1 to 2 milligrams, slow IV push. Indomethacin may be given in the hospital. We don't carry it, but it's something you should be aware of and somewhat familiar with. It's an NSAID that decreases the production of prostaglandins, which are associated with the initiation of labor. It's typically not used after 32 weeks in order to avoid the premature closure of the ductus arteriosus, which is what allows the fetal circulation to bypass the the pulmonary circulation. Contraindications. Contraindications include GI bleeding, ulcers, severe cardiovascular, renal, or hepatic disease. Adverse effects on mom, nausea, vomiting, dyspepsia, and additive central nervous system effect if given with MAG. Adverse effects on fetus include premature closure of ductus arteriosus. There is no antidote. You just have to discontinue the drug. Precardia is something else that you may see in the hospital. It's a calcium channel blocker. Some contraindications include sick sinus syndrome, second or third degree AV heart block, systolic less than 90. Adverse effects on mom include a headache, flushing, additive CNS effect if given with MAG. Adverse effects on fetus are minimal, and there is no antidote. Just have to discontinue the drug. Further management of preterm labor during transport. Always get you a couple of large bore IVs. Always put your mom on oxygen. Always try to treat the underlying cause. Consider a fluid bolus if there's no pulmonary edema or severe hypertension. Aggressive tachylysis and comfort measures. Decreased stimulation, and rapid transport to an appropriate facility. We do have a preterm labor SMP. It's SMP number 310. And quick rundown, they expect you to time your contractions and monitor fetal heart rate. You're assessing for fetal distress, bradycardia, tachycardia, late D cells. Your fetal heart rate should be assessed and documented every 10 minutes for preterm labor. Left and right positioning. Tocolytics, medical control should be contacted prior to initiation of tocolytics if needed. In case contact cannot be established, proceed per the SMP and notify medical control as soon as possible. That may be when you land, you may be so busy, it might be after the flight. That's okay. If you know it's the right thing to do, then that's what you need to do. And we can deal with the paperwork after the fact. If contractions are unresponsive to medical intervention and therapy, always contact medical control. You can do that from your sat phone in the air. And if there's fetal distress, always contact medical control. And again, you can do that from the air. Premature rupture of membranes. Rupture of membranes prior to 37 weeks. You'll notice mom will notice a clear watery vaginal discharge, possibly continuous, odorless, colorless fluid. You're going to avoid a digital vaginal exam due to the risk of infection. Speculum exam will help to diagnose or nitrazine paper with a pH within these guidelines here. On the ferning, they'll do the exam, they'll get the fluid, they'll put the fluid under a microscope, and they'll notice what they call ferning. It's an amniotic fluid pattern, and that's a positive diagnosis of premature rupture of membranes or an ultrasound. Chorioamnionitis, the definition of that is inflammation of the membranes that surround the fetus, usually bacterial beta strep, that can be treated with antibiotics. It possibly might lead to uterine tenderness, uterine contractions, maternal pyrexia, maternal fetal tachycardia, vaginal discharge, which may be foul-smelling or discolored. Increased risk if the latent period or the time between the rupture of membranes and the onset of labor is longer than 24 hours. Development of chorioamnionitis can lead to sepsis and death. And so risks of fetal and or maternal infection, sepsis, and perinatal mortality increase with every hour and with every vaginal exam or other invasive procedure after 24 hours. So that's why we don't want to do any pelvic exams. If the membranes have been ruptured, you want to let the practitioner do it, and you want to let them do it with a sterile speculum. Therapeutic interventions involve hydration. You can maybe get the fever down and, of course, help their hydration status with some IV fluids, tocolytics, antibiotics, steroids, observation, and transport to a center with NICU. Treatment depends on the fetal age and the risk of infection once you get there. In a term pregnancy, within 24 hours of rupture, labor is usually induced with oxytocin or C-section performed if induction fails. If it's a preterm pregnancy, less than 34 weeks, they're going to try to keep baby inside until lungs are a little bit more mature. And so they'll typically hospitalize mom and observe her signs of infection, and they'll wait a little bit till the fetus becomes more mature. If infection is detected, then they'll go ahead and induce labor or give an antibiotic. And this is just really cute. Hypertensive disorders in pregnancy. That's old terminology is pregnancy-induced hypertension or toxemia. New accepted terminology is chronic hypertension, gestational hypertension, preeclampsia, or eclampsia. That's still a hotly debated item in my book. And in a lot of people's book, I'm sure, you know, a lot of us were taught pregnancy-induced hypertension versus chronic hypertension. In my opinion, they're two very different things, but anyway, moving along. Gestational hypertension is a systolic over 40 or diastolic over 90, or either reading over 30 above their normal. So proteinuria also, which causes damage to the glomerulus, over 300 milligrams in 24 hours of urine, or a 2+ dip times 2, 6 hours apart. Edema or third spacing fluid due to lack of protein. It's usually non-dependent. It can be in their hands, their face, or around their eyes especially. Sometimes they'll have weight gain over or around 2 pounds a week. Here we are, especially the face and hands early in the day. Gestational hypertension occurs in 5 to 10% of all pregnancies. It's a significant cause of maternal mortality, as well as a significant cause of neonatal morbidity, responsible for approximately 25% of all maternal and fetal preterm deaths. Most often occurs in first pregnancies. Other risk factors include young moms, older first-time moms, no prenatal care, multiple gestation, lower socioeconomic status, renal disease, diabetes, and lupus. Gestational hypertension is classified as preeclampsia, eclampsia syndrome, chronic hypertension superimposed preeclampsia, or transient late hypertension. Gestational hypertension usually has an onset of over 20 weeks, usually in the late 3rd trimester, in fact. There's no protein until later when it becomes preeclampsia. Not associated with adverse outcomes unless blood pressure is greater than or equal to 160 over 100. The earlier the onset, the greater the risk of developing preeclampsia, especially less than 30 weeks. Preeclampsia is a form of hypertension that's unique to human pregnancy. It's characterized by vasospasm, endothelial damage, increased capillary permeability. Etiology is unknown. Many theories are proposed, but none have been proven at this point. Eclampsia is severe gestational hypertension with the onset of seizures. The cure is the delivery of the fetus. So the only difference between preeclampsia and eclampsia is the seizure activity. The triad, a preeclampsia triad, is hypertension, proteinuria, and edema. Risk of progression to eclampsia is seizures, grand mal seizures, usually with no past seizure disorder or history, and this carries a significant morbidity. Eclampsia warning signs include a headache, frontal or occipital usually, visual disturbances, hyperreflexia or clonus, epigastric pain, usually in the right upper quadrant, and anxiety or a sense of doom. If your mom has that sense of doom, usually there's a good reason and you need to further investigate rapidly what you can do. Other signs and symptoms include hypertension, edema, excessive weight gain, extreme swelling of the face, hands, and feet. We've already discussed these. Sensitivity to light, apprehension and shakiness, Increased BUN, creatinine, and uric acid levels. As we discussed earlier, they're normally decreased. At this point, they're going to be increased. It's causing, that's the damage from the protein through the glomeruli, and it's causing your BUN, creatinine, and uric acid levels to increase. She'll be nauseous and possibly vomiting. Risk factors include young moms and old moms. I say old moms, really, I just mean over 35, which is not old, but apparently in the pregnancy world, they think it is. So vascular disease, hypertension, diabetes, and obesity, ethnicity, prior history, null parity, new partner, new sexual partner, or multifetal gestation. Management of preeclampsia includes 100% oxygen, left lateral recumbent position, avoid excessive stimulation. This is when you'll want to maybe cover their eyes and give them ear protection, and avoid the use of emergency lights and sirens if at all possible. If it's not resolved, preeclampsia will deteriorate to eclampsia. The difference is seizures, and if a seizures go untreated, mom will end up in a coma. If the coma goes untreated, then she will die. Eclampsia is the gravest form of pregnancy-induced hypertension, and it occurs in less than 1% of pregnancies. It's usually seen near term, during delivery or post-delivery. And you are going to assess every pregnant patient for increased blood pressure, for edema, protein in the urine. You're going to ask the nurse, or you're going to check their chart yourself. And you're going to take all reports of seizures in pregnant females seriously, because that 1% could equal seizures, coma, and death. And that would be rather unfortunate if it was, your patient and there was something you could have done to prevent that. S&P 35 outlines your expectations, guidelines, what you can do in the event of preeclampsia and eclampsia. The high points include, like we discussed already, decreased stimulation, hearing protection, dark environment, maternal and fetal vital signs at least every 10 minutes. You're going to include a temp and identification of fetal distress. This will assist in identifying the appropriateness of the transport or need for a maternal transport team if fetal distress is noted. If you decide there is fetal distress noted, you've contacted medical control, you've decided that maybe a specialized maternal team needs to take this mom, then you can stay and you can help care for the patient. Let OCC know. They'll make all the appropriate calls, and they'll help you to find a team that is maybe better suited to take that patient, and we will gladly assist in any way that they want us to. In the meantime, we'll turn mom on her left or her right side, and we'll try to prevent fluid overload and monitor her eyes and nose closely. Hypertensive medications that can be utilized include hydralazine. The dosage of that would be 2 to 5 milligrams IV push every 15 to 20 minutes until her blood pressure begins to decrease. You'll stop when the diastolic is 90 to 100, or a total of 30 milligrams is given. That's your max 30. Implications: closely monitor blood pressure and cardiac activity, urine output, consult medical direction, monitor fetal heart tones and contractions as needed. You can also give labetalol, a loading dose of 10 milligrams IV push, slow, followed by 20 milligrams at 10-minute intervals until a total dose of 300 milligrams is given, or a diastolic of less than 110. Decreasing diastolic below 90 to 100 could cause severe fetal distress, so watch out for that. Seizure prophylaxis, of course, mag sulfate. Like we mentioned earlier, your bolus 4 grams over 15 minutes. You're going to get your baseline DTRs, and preferably before the bolus is given. If the sending facility is already given the bolus before you get there, use the DTRs upon your initial assessment as your baseline, because it's better than nothing. And maintenance dose of 2 grams per hour, increases warranted up to max dose of 4 grams per hour of MAG. DTR should be assessed and documented every 15 minutes at least. Monitor patients receiving MAG for toxicity. Discontinue use for MAG over 7 urine output less than 30 an hour, loss of deep tendon reflexes, severe hypotension, decreased LOC, bradycardia, or decreased respiratory rate less than 12. Your antidote, like we mentioned earlier, is calcium gluconate, 1 gram of 10% solution over 1 to 2 minutes. Or if you don't have that available, calcium chloride, 500 milligrams, slow IV, not to exceed 1 milliliter per minute. Control of active seizures, mag bolus and drip, Versed 0.1 milligram per kilo with max dose of 10. More information. During seizure activity, the placenta can separate from the uterine wall, and this can cause hemorrhage, so this will complicate your day drastically. Death can result from cerebral hemorrhage, respiratory arrest, renal failure, and circulatory collapse. On a side note, nipride, try to avoid it if at all possible. It can cause significant fetal compromise. Some fetal complications, gestational hypertension include growth retardation, fetal distress, abruptio placenta, and fetal death. Maternal complications include pulmonary edema, DIC, renal failure, hepatic failure, liver rupture, HELP syndrome, which stands for hemolysis, elevated liver enzymes, and low platelet count. HELP syndrome occurs in pregnancies beyond 24 weeks usually. HELP is often misdiagnosed as either acute chronic cholecystitis, hepatitis, epilepsy, idiopathic thrombocytopenia purpura, or fatty liver disease of pregnancy. This refers to a category of gestational hypertension that primarily changes blood components and liver function. Patients with severe preeclampsia are at high risk for HELP syndrome. Maternal and infant mortality is high, and the exact cause is unknown. After birth, lab results usually return to normal within a week, and the mother experiences no further problems. Assessment at this time would involve pain. Where's it at? It's right upper quadrant, usually epigastric area or lower chest. Nausea, vomiting, general malaise, severe edema. Right upper quadrant, possibly tender on palpation because of the distended liver. So you might want to not palpate that too much. And signs and symptoms of preeclampsia. Diagnostic test findings include hemolysis of red blood cells, thrombocytopenia, and elevated liver enzymes, more so than your normal minimal increase. Management will include ICU, MAG, and transfusions of FFPs or platelets to reverse the thrombocytopenia, and delivery of the fetus as soon as possible. Interventions also include, you're going to monitor vital signs and fetal heart tones, watching for complications including hypoglycemia and hemorrhage, seizure precautions, low stimulation, avoid palpating the abdomen. You don't want to accidentally rupture the liver, and bleeding precautions, of course. Complications include fetal and maternal death, hemorrhage, hypoglycemia, hyponatremia, liver hematoma, or renal failure. Placenta abruption versus placenta previa. Vaginal bleeding during pregnancy should always be taken very seriously. It's not normal, and until a proper diagnosis is determined, it's prudent to assume that any vaginal bleeding during pregnancy is potentially life-threatening. Your normal placenta attachment, the placenta is usually at the top, and so when that attaches in weird places, it causes problems. Abnormal attachment, maybe either covering the cervical os or maybe not attaching so well. Part of it can hemorrhage. A lot of blood can actually get caught in between the placenta and the uterine wall, and you can lose a great deal of blood before you even know mom's hemorrhaging, and without any indication outwardly. So abruption would involve premature separation of the placenta from the uterine wall, usually before 20 weeks. She can bleed externally, like 80% of patients, or 20% of patients bleed internally, and you never know until they start showing signs of hypovolemia. It's usually classified according to the degree of placental separation as well as the severity of maternal and fetal symptoms. Prognosis depends on the gestational age and amount of blood loss, obviously, and maternal prognosis is good if the hemorrhage can be controlled. If you catch it early enough and control the hemorrhage, then mom's usually in good shape. Here's just a couple of pictures. One of them you can see is bleeding internally, and one of them, the blood is actually leaking out the cervical os. A couple more pictures. High-risk groups include older pregnant patients, over 35, hypertensives or gestational hypertension, multigravidas, trauma, cocaine use, low socioeconomic status, low folic acid levels of vascular or renal disease. Signs and symptoms: mild to moderate vaginal bleeding, bright red or old blood, continuous knife-like abdominal pain, rigid tender uterus. And the stuff in the blue here is key to remember because we're going to compare that later to placenta previa, which will be a little different. So signs and symptoms of hypovolemia will also be apparent: a rapid progression to active labor, fetal distress, your heart tones will eventually become barely audible, bradycardic, and turn into nothing at all. Diagnosis is mainly clinical based on findings of vaginal bleeding, abdominal pain, uterine tenderness, uterine contractions, and fetal distress. Abruption may be suspected diagnosis. However, it is often not a confirmed diagnosis until postpartum examination of the placenta. Complications, of course, for mom include hemorrhagic shock, coagulopathy, DIC, uterine rupture, renal failure, ischemic necrosis of distal organs. Fetal complications include hypoxia, anemia, growth retardation, central nervous system anomalies, and fetal death. Management includes, like always, 100% O2, left lateral recumbent position, 2 large bore IVs, aggressive tocolytics, reassess vital signs of fetal heart tones, often possible volume expanders, and supportive care for hypovolemic shock. Okay, so placenta previa is when the placenta is actually covering the cervical os, which is different than placenta abruption, which is where the placenta can be anywhere in there, just kind of breaking away from the inside of the uterus. So with placenta previa, implantation is over the cervical opening. Signs and symptoms are painless, bright red vaginal bleeding, soft, non-tender uterus, and signs and symptoms of hypovolemia. So some similarities: both of them are going to be hypovolemic, but one of them will have painless, bright red vaginal bleeding, and your placenta abruption will have painful, sometimes dark, can be bright red, but it can be dark red, but it will be painful, and the uterus can actually even get hard and board-like. So those are some of your differences. Etiology: no specific cause has been found. The following conditions are associated with increased incidence: increased parity, closely spaced pregnancies, previous C-section, advanced maternal age, abnormal fetal presentation, congenital anomalies, endometriosis, male fetus, anemia, multiple gestations, smoking, previous abortion, tumors that distort the uterus. This occurs when the placenta implants in the lower uterine segment where it covers the cervical os, and there's 3 types. It can be low, partial, or total. Factors: multiple gestations, previous uterine surgery, multiparity, advanced maternal age. We just discussed that. Common cause of bleeding in the third trimester, placenta previa. And then here's a little picture. And another picture. Assessment findings, bright red bleeding after the 20th week, painless, starts and stops spontaneously. However, it will increase with each incident usually. Again, soft, non-tender uterus. Leopold's maneuver reveals various malpresentations, and the fetus remains active, usually with audible heart tones, so that's good. Diagnosis is suggested by painless vaginal bleeding with or without clots. Ultrasound is a highly accurate method for diagnosis, and in a small percentage of patients, a double setup examination may be indicated. Management involves you expecting a patient to receive Rogram at the hospital if they're Rh negative. Expect your patient to receive betamethasone for maturation of fetal lungs. An additional dose will probably be given at 24 hours and again in 2 to 3 weeks. Management, of course, as always, 100% O2, left lateral recumbent position, limit her movement, 2 large bore IVs, monitor vital signs, fetal heart tones, aggressive tocolytics, control any bleeding, supportive care for hypovolemic shock, consider a Foley, and never perform a vaginal exam on a patient in the 3rd trimester with vaginal bleeding, as we have already discussed. And here's just a little list of the comparison. Abruption, painful bleeding, dark and non-clotting, blood from fetus and mother, primary danger to the mother, and C-section is not mandatory. Previa, painless vaginal bleeding, it's painless, characteristically bright red. The blood's only from the mom. Primary danger is also to the mom, and C-section is mandatory. Uterine rupture causes blunt trauma to your pregnant uterus, prolonged labor against an obstruction, and labor against weakened uterine walls, say an old C-section scar or grand multiparous patients. Signs and symptoms, they may feel a tearing abdominal pain, severe hypovolemic shock, firm, rigid abdomen, possible palpation of fetal parts through the abdominal wall. Vaginal bleeding may or may not be present, and of course your management, 100% O2, and you will anticipate shock and treat accordingly. Any 3rd trimester bleeding, oxygenation, and fluids. Always, always, always oxygen, fluids, proper positioning. Consider blood administration if it's a large amount. You may have to take some from the hospital, that they give you. You don't want to just take it. They'll give it to you. Vasopressor therapy. On a side note, this is not in our OB protocols. This would be in life-saving mode only, and this would be a protocol deviation, would require a protocol deviation form, but as long as it was indicated, then this is what you might consider doing. Dopamine, 2 to 4 mics per kilo per minute. If you keep that dose low, then it tends to preserve the placental blood flow. Levofed, used in life-saving mode only because this will decrease the fetal blood flow. Dobutamine, 5 to 15 mics per kilo per minute. And like I said, only in life-saving mode. And at that point, you'll probably consider resorting over to your hypovolemic shock protocol and keeping in mind that there is a baby on board. So if you could keep those doses low, if at all possible, it will benefit the fetus more. Fetal monitoring. You can monitor fetal heart rate and uterine activity with external or internal monitoring. We will not take an internal monitor with us. Usually they take out the internal monitors at some point before they get too far along. Some ways to evaluate your fetal well-being in the field include presence of fetal movement, auscultation, external fetal monitoring, internal fetal monitoring if they have it set up before you get there, biophysical profile, and amniotic fluid index. You can auscultate fetal heart tones via Doppler, normal rate 110 to 160. You cannot detect long-term variability or short-term variability with just a Doppler. If you hear a gallop, that's baby. A swishing is more the placenta. You can differentiate maternal pulse versus fetal heart rate. And one way to do that is once you hear the heartbeat or the gallop or the thumping, then look at your monitor and see if it meets up with your mom's heart rate on your cardiac monitor, or if it's faster. Mom's heart rate will typically be slower. Baby's heart rate will be a lot faster and even difficult to count. So that's how you'll know the difference. Document at least every 10 to 15 minutes during transport. External versus internal monitoring. Your external fetal monitor or your TOCO versus your fetal scalp electrodes and the intrauterine pressure cath monitoring. Your external monitor is non-invasive, uses ultrasound frequencies to assess the fetal heart rate, long-term variability, and periodic changes. TOCO provides quantitative info only, and it sometimes has more artifact. Your intrauterine pressure catheter or fetal scalp electrodes will be more invasive, increasing your risk of infection. Fetal EKG, though, you do get a better reading. It's more accurate. You can assess your fetal heart rate, long-term and short-term variability, and periodic changes. The membranes must be ruptured in order to do this. So like I said, you increase your chances of infection. And electrode attached, it will be attached to the fetal presenting part. So if the feet are presenting, then you may not get the best reading. If the elbow is sticking out, then that might be more difficult to get an accurate reading. Usually it would stick to the baby's head if they're in proper position. So here's your external monitor and your internal monitor, or your fetal scalp electrode. And then your intrauterine pressure catheter, it measures the contractions. And then you can see the fetal scalp electrode actually just sticks to the baby and measures the baby's heart rate and stuff. Your transducer placement for ultrasound is the black dot there. You can see on the first picture, the baby with his head down. He's kind of got the black dot on his chest. That's where you would want that monitor if the baby's in that position. If your baby's breech, you can kind of put it up at the top, right there on the back, and so on. Basically, you just want to find the baby's back or chest and in whatever position they're in, and that's where you're going to want the monitor where you can best hear the baby's heart rate. The goal of your monitoring is to prevent hypoxia and asphyxia in the fetus and the newborn. Remember that 2/3 of the damage is caused antepartum and 1/3 of it happens during intrapartum period. This hypoxia and asphyxia can cause cerebral palsy, chronic brain impairment, mental retardation, epilepsy, renal damage. It can lead to necrotizing enterocolitis, not to mention a pretty hefty lawsuit. The liability is rather large for those delivering babies. So your display. The intervals between the vertical red lines represent 1 minute. So the fetal heart tracing is on the top and mom's uterine activity is on the bottom. So forever and ever for always, that's what it's going to be like. Mom's on the bottom, baby's on the top. I like to remember it as mom is heavier, so she's going to be on the bottom. Baby's lighter, so baby's information is always going to be on the top. And just remember 1 minute in between the intervals. You're going to monitor contractions. This is one way to do it. There's 3 phases. There's the increment, the acme, the decrement. I'm not sure how to say that word, so sorry. And then relaxation. Characteristics, the duration is measured from the beginning of the increment to the end of the decrement. Frequency is from the beginning of one to the beginning of the next. And intensity is measured during the most intense phase. Normal is 30 to 50 millimeters of mercury and 5 to 15 while resting. So I know you can't see the words on this slide very well, but you can kind of get the idea. The beginning of one to the beginning of the next. And then you can also see how long the actual contraction lasts and then how tall the hill gets. So those are the three things you're measuring. Fetal heart rate patterns. There's multiple patterns that we are about to discuss. Early decels are from head compression usually and normally range from 120 to 160 beats a minute. They're not associated with fetal difficulties. They usually appear as uniform smooth waveforms and they're inversely mirror the corresponding contraction. So you'll treat this with IV, O2, position change, tocolytics if needed. Here's a good picture of some early decels and see how they inversely mirror the contractions. That's just pressure on the head. Late decels, that's a bad sign. So this is the bad, caused by uteroplacental insufficiency. They appear as uniform smooth waveforms that inversely mirror the corresponding contractions, but they have a late onset in relation to the most intense part of the contraction. They might drop below 100 beats per minute when severe, and this is considered an ominous sign if persistent and uncorrected. You can't take this mom with you while baby's having late decels. You have to contact medical control, and you need to correct that before you put this person in your aircraft. Some ways that you might be able to correct that would be always O2 IV positioning. Immediate delivery is indicated if fetal stress cannot be corrected. Here's a good picture of a late decel. And see how the most intense part of the contraction is where the start of the deceleration is, and that's where the baby's heart rate starts to kind of drop. Another picture of late decels. And if you line it up, you can see the most intense part of the contraction is where the late decel starts, and then it lasts for almost a full minute after. Interventions: treat prior to transport. If unresolved, contact medical control. Put your patient on her left side, bump up her IV and give her some oxygen, and try to identify the underlying cause. Variable decelerations can be caused by umbilical cord compression. There's not really a uniform appearance, and they kind of vary in their onset, occurrence, and waveform. It just kind of changes. In severe cases, it may be below 70 beats per minute for more than 30 seconds, maybe periodic or non-periodic, usually transient and correctable, and it occurs in about 50% of labors, and it's not really associated with low APGAR scores. This picture isn't very good, but you can tell that there's not really any rhyme or reason to the decels, and the contractions are pretty steady and regular, but the decels are just kind of sporadic, and they drop for a minute or for a second, but remember, between the big lines is 1 full minute, so that's not really dropping for that long. This is mild, and then this would be an example of a severe deceleration. That one, you don't want to O2, position change, pump up our fluids, try to identify the underlying cause. Interventions: continue to monitor, record fetal heart rate as well as contraction duration, frequency, and duration. No further intervention is necessary unless fetal distress is noted or unless those decels become really severe. Assess for reassuring signs. Reassuring signs include baseline that's not increasing, short-term variability that isn't decreasing, decels that abruptly begin or end, and decels that last less than 50 seconds. If no reassuring signs, then notify medical control. This picture is also not the best, but it does help a little if you're a photo person like me. The first one, early decels, is head compression. Late decels is fetal distress, and baby's obviously not getting enough oxygen, so blue. And then the cord compression would be your variable because your cord can move around, your baby can move around, and so it's kind of changing constantly. So what is this to you, and what are you going to do about it? Well, it is a late decel, and so in this particular case, you're going to put mom on oxygen, flip her on her side, bump up her fluids, and call medical control. Or notify the physician on scene and just let them know that you need to correct this fetal stress or distress before you take this patient. So moving on, accelerations, brief increase in fetal heart rate of at least 15 beats above the baseline that usually lasts 15 to 20 seconds, usually above 150 beats a minute. It's caused by fetal movements or contractions, uniform or variable, and this indicates fetal well-being and requires no intervention. Here's an example of accelerations. And the second one is long-term variability. It's consistent. Baseline variability, normal cardiac irregularity caused by interplay of the parasympathetic and sympathetic nervous systems. This appears as slightly irregular or jittery on the waveform. Short-term variability is just beat to beat changes in the baseline, and long-term variability refers to the rhythmic fluctuations in waves, usually 3 to 5 times per minute, and it ranges from 6 to 10 beats per minute and occurs 3 to 10 times per minute usually. And it's pretty consistent usually. Baseline variability indicates adequate central nervous system function, increased by stimulation of the fetus, slowed by sleep, analgesics, and anesthetics. Requires no treatment unless fetus shows signs of distress. Baseline of the fetal heart rate is the average fetal heart rate over 10 minutes. So this is rounded to the nearest 5 beats per minute. Here it's 145. Increased variability is caused by early mild hypoxia and fetal stimulation. This is the earliest sign of mild fetal hypoxia. Requires careful evaluation of fetal heart rate for signs of fetal distress. Some moderate variability here. This would be marked variability, obviously. Decreased variability is caused by hypoxia, and that's an ominous sign if it's uncorrectable. Acidosis, central nervous system depressants, and other drugs can be ominous if associated with late decels. Requires repositioning of patient to left lateral position and administration of IV fluids and oxygen. Minimal variability here. And this would be absent. Short-term variability, beat-to-beat changes, sympathetic nervous system documented as present or absent. Long-term variability, cycles per minute. Parasympathetic nervous system, cycles of greater than 25 beats, and documented as absent, decreased, normal, or marked. So how do I treat fetal stress? Same way we've been treating it this entire time. Your ultimate goal is to improve oxygenation and blood flow. So you're going to treat mom first. You're going to give oxygen, IV fluids, aggressive tachylysis, and maternal positioning. You're going to change your position. You can put her in the knee chest position. You can elevate the presenting part, elevate her hips, amnioinfusion. So intermittent assessment, auscultation every 5 to 10 minutes, fetal heart tones, listen for 30 seconds, record the rate, should be 120 to 160. Every 15 minutes, at least, you're going to document maternal vital signs and fetal heart tones, and definitely going to get those vital signs in the golden hour. You use a fetal monitor if transport time is over 20 minutes or greater, and if unable to get a tracing chart, so go ahead and document why, whether it was positioning, turbulence, whatever. And that's it for that part. There's still a bit more to come. Precipitate labor refers to labor lasting 3 hours or less, more common in multiparous patients. Assessment findings include strong contractions with signs of premature placental separation, cervical dilation of more than 5 centimeters an hour in a nulliparous, or a greater than 10 centimeters per hour in a multiparous patient, and that is really fast. Precipitous labor, if imminent delivery is noted, notify medical control, consider diversion to the nearest facility. Some signs of imminent delivery include rupture of membranes, crowning, and the urge to push. Treatment would be a tocolytic may be administered to reduce the strength and frequency of contractions. Plans for immediate delivery are commonly necessary and encourage the patient to relax as much as possible. And of course, keep calm yourself, at least on the outside. So be familiar with what you have available to you, what is in your toolkit. Be familiar with the contents that and how to use them. Currently our OB kit includes the following: 1 pair of disposable sterile gloves, although you have 2, 3, or 4 other pairs in your bags should you need them. 1 drape sheet, 2 umbilical clamps, sterile, 2 OB towelettes, 2 alcohol preps, medium, 1 OB pad, sterile, and 1 plastic bag for the placenta. You'll also have 6 gauze sponges, a bulb syringe, 4 disposable towels, 2 nylon tie-offs, 1 disposable scalpel, 2 twist ties, and 1 receiving blanket. And this is pretty much what it looked like. And keep in mind that you've also got, excuse me, you've also got other tools available to you. You've got burn sheets and other things in your bags that you can use should you happen to have 2 babies. You've also got 2 meconium aspirators. So also remember that this is a clean procedure. It's not really a sterile procedure. You want to keep it as sterile as possible and use your sterile gloves, et cetera, but you just try to do the best you can with what you have and try to keep it as clean as possible. Always make sure your mom's on a cocoon, whether it's 110 degrees outside or 30 degrees outside. I know the cocoons tend to keep them warm, but it will also keep fluids inside and keep you from having hours decontaminating your plane afterwards, or your aircraft. So emergency childbirth, labor. There's several stages. First stage would be the onset of contractions to the dilation of the cervix. Second stage, complete dilation to delivery of the baby. Third stage is delivery of the placenta. Crowning is present. Imminent delivery, you will know because baby will be crowning, or other body part will be presenting. Contractions will last 30 to 60 seconds and are 2 to 3 minutes apart. Mother has the uncontrollable urge to push and membranes are ruptured or bag will be bulging. And be ready to support her with delivery and have your OB kit open and ready. This is a really good time to be discussing with your partner which person's going to take what role, who's going to take care for mom, who's going to take the baby, and kind of coordinate that. Imminent delivery. Ensure your scene is safe. Remember, this is a natural process. Women have been delivering babies perfectly fine for hundreds of years. And so you can too. It can be totally okay. And remember, this is a clean procedure. It's not sterile. You just do the best you can with what you have. Protect yourself. Make sure that you wear PPE, a lot of it. Get your patient's attention and remember that only one of you can give directions. She's got too much going on to be trying to focus on more than one person. One of you needs to maybe even get in her face and get her attention and say, okay, I'm your person, focus on me, nothing else right here. And she'll be more inclined to listen to just one person than to 2 or 3 people trying to bark orders at her. Always protect her privacy. She will be more relaxed and it will just go much smoother if she doesn't feel like it's more of an invasion than it already is for her. So, mom's gonna need a clean, dry area. PPE you're gonna need for her or for yourself: PPE, gloves, gown, eye protection. Towels, blankets, anything that can absorb fluid, delivery kits, IV access, of course, and monitoring equipment. Baby's going to need blankets, cord clamps, scissors, scalpel, heat source, which can be mom's chest, suction device, bag and mask, airway, tape, gloves, clock, stethoscope, oximeter. All these things you should have access to. And you cannot tie her legs together and you can't scream for help. So just push that out of your head. It's not going to happen. Can't do it. Sorry. Sadly. Remember standard precautions. Gown up, get your eye protection on, put a mask on, and go ahead and put some gloves on. It can be kind of an explosive deal here. So make sure that you protect yourself. For delivery, plan with your crew where you're going to put the baby and collaborate with each other so that one of you takes care of the mom, one assumes care of the baby, and make sure you don't touch the vaginal area except to deliver and in the presence of your partner. Help position your patient into a position where delivery can be performed and create a sterile field around the vaginal opening. Stay calm. Ensure your mom's as comfortable as possible. Keep her dignity about her. Try to remember that she is not trying to show all her business to everyone. And I'm sure if it was her choice, she certainly wouldn't be doing it right there in front of you. So try to help her to maintain her own modesty and peace of mind. So baby can present in many different ways. Here's a couple of examples. Normal presentation would be head down, facing backwards. Less common, sunny side up, head down still. And then over the next series of pictures here, you'll see how the fetal position changes during delivery. Right now, the head's floating before engagement. As soon as the bag of waters break, probably the baby's head will float on down and become engaged into the pelvic cavity, in which case then the head will likely turn kind of sideways. Baby does this little cool twisty thing, and baby's head is now engaged. And at the top right-hand corner, you can see that's the crown, and so the head's kind of tilting a little bit. And then we have one shoulder, the one on top, and then the one on the bottom. And here we go with the graphic pictures. So when baby's crowning, go ahead and support the perineum and place a gloved hand on the presenting part to prevent an explosive delivery. And on the delivery of the head, go ahead and suction the mouth first and then the nose. Always suction the mouth first and then the nose. I apologize for my little PowerPoint here. Gently guide the baby's head down to deliver the upper shoulder, and then guide the baby's head up to deliver the lower shoulder, and then gently assist with the delivery of the rest of the baby. Don't pull the baby out. Baby will come. Like I said, women have been delivering babies naturally for years, and it's a process, and the baby will come. So you don't have to rush it too much. Just do note the time that the baby was delivered. Try to control the slippery baby during delivery as much as possible. Support their head, shoulders, and their feet. Keep their head lower than their feet to facilitate drainage of secretions from the mouth. And of course, dry the baby, keep the baby warm. A lot of times mom is warm, and so putting the baby directly on the mom's chest will help to, as long as the baby is doing okay, then it can help to keep the baby warm. It depends on the situation and how you think your mom would handle that. Here's a picture of them putting a little counter pressure on the head and supporting the perineum. And here they're checking for the cord wrapped around the neck. And then they're suctioning the mouth and the nose, checking for the cord, and allowing the mom to work with the contractions and rest in between. So a prolapsed cord, that will absolutely compromise the O2 delivery to the baby, and it will compress the cord. This is an emergency, so you need to have the mom breathe through the contractions if at all possible. You don't want her pushing. That's just going to put more pressure on the cord and stop the oxygen delivery to the baby. You're going to insert a gloved hand into the vagina and push the infant's head away from the cord, and you may have to hold it there, hold it off the cord until the repositioning or till something else happens. Elevate the mom's hips or put her in the knee chest position or put her in Trendelenburg. That all might help alleviate the pressure on the cord. And the cord, if it is actually all the way sticking out, should be kept completely sterile, covered with a warm, wet towel if exposed, and try to prevent the temperature from dropping and causing artery spasms. You'll absolutely consult medical control, divert to the nearest facility with OB capabilities. Here's another picture. This is a picture of how the baby's head will naturally kind of turn to one side. You just want to support the head. You don't have to pull. And they're suctioning. And they're getting ready to deliver the shoulders. Here we're checking for a nuchal cord. Guide the head down to deliver the anterior shoulder, and then back up to get the posterior shoulder. And here's some shoulders. So once your baby's delivered, you're gonna clamp and cut the cord about 8-ish inches from the baby. Some people say 6, some people say 10. Leave enough room for you to be able to get UVC if you happen to need an IV or umbilical vein catheter, but don't leave it so long that it's dragging the floor. Second, you'll clamp 2 inches farther away from the first, and you'll cut in between those clamps, and you'll use the umbilical tape, if you have any, to control any bleeding from the cord. You'll also make sure baby is completely suctioned until secretions are clear, mouth, then nose. You'll inspect mom's perineum. You'll apply counter pressure to the laceration to prevent any bleeding. If she has a laceration, you'll place a newborn on her chest and then book it to the hospital. Placental separation so once the baby's born, mom's abdomen should change shape a little bit. And then you'll know that the placenta is separating and about to deliver because the uterus will also change shape again if you can see it. Lengthening of the umbilical cord and increasing vaginal bleeding. And then once the placenta is delivered, you'll put the placenta in a plastic bag and take it to the receiving facility as well so they can inspect it and make sure that it's complete and that there's no product still left in mom. That's a bigger problem. So in summary, IV fluids, oxygen, positioning, privacy, push with contractions, control the delivery, support perineum, suction after the head delivers, suction mouth, and then nose, and check for a nuchal cord as baby's coming out. If meconium is noted, then you'll suction with a delete suction. You'll do the mouth and then the nose, and we actually have some meconium aspirators that you'll need to go ahead and get a good visual on the vocal cords before, and then just try to clean out as much as you can before baby takes his or her first big gasp of air. Also, remember, once the head comes out, you'll support the head. You'll pull the baby's head down a little. Well, you'll support the baby's head while delivering the anterior shoulder, and then you'll kind of turn the baby's head up a little bit to deliver the posterior shoulder. As the torso and body deliver, support the baby completely with both hands. Remember, the baby's going to be really, really slippery, so don't drop the baby. Repeat suction, mouth and nose. Clamp and cut the cord. Drive vigorously. You may have to use your NRP guidelines and skills. You'll keep baby warm and dry, and you'll check APGAR scores at 1 minute and then at 5 minutes, which is actually at 1 minute and then 4 minutes later. So that's 5 minutes. So initial vital signs, reevaluate, and now you have 2 patients. And remember, when you're caring for your neonate, that their O2 sat will take a little while to come up, and that they take a few minutes to acclimate to the world around them. So be prepared in what changes to expect and what your timeline is. So delivery complications, breech deliveries, about 3% of babies are breech, and this does increase the likelihood of a prolapsed cord. Occurs in 3 to 4% of all deliveries at term, many different types. So you can get a footling or a frank or complete. The most important thing to remember is to not rush the process. They allow the fetus to deliver spontaneously if possible up to the umbilicus. And remember, a breech baby usually takes a little bit longer to deliver. The buttocks will deliver first. Support the body as you normally would. The head is almost always face down and should be allowed to deliver spontaneously. Make a V with your gloved fingers and position them in the vagina to keep the walls from compressing the infant's airway. And you may be stuck there for a minute. Here's a couple of pictures. On rare occasions, the presenting part of the infant is a single arm, leg, or foot. This is a surgical emergency and usually must be dealt with immediately. So you'll cover that limb with a sterile towel and give mom high flow oxygen. You'll call medical control. You'll divert to the nearest facility with OB capabilities, and you'll prepare to assist with the delivery and resuscitation of the baby. Here's a couple of different variations, a complete breech or an incomplete or a frank. For a breech delivery, you'll support legs and pelvis. After the umbilicus is visualized, gently extract the cord to allow for delivery. Gentle traction downward, don't pull. Support baby with palm of hand and the surface of your arm. Gently rotate the fetus to align the shoulder at anterior posterior position, and guide the infant up to deliver the posterior shoulder and then down for the anterior shoulder, and then avoid excessive head and spine traction. And we'll get into some more graphic pictures here. Watch a little breech baby be born, some little feet. Do not apply excessive traction to the cord. Counter traction to the uterine fundus will probably be needed. Examine placenta for vessels and cord. There should be 3 vessels, 2 arteries, and 1 vein. And it will kind of look like this little happy face right there. Your 2 arteries are the circle ones, and your vein will be the flat one. Placenta normally separates within 20 minutes, maybe up to an hour. Signs of placental separation include a sudden gush of blood from the vagina or cord lengthening, and you'll deliver the placenta to the receiving facility. You'll do fundal checks and vital signs Q 15 minutes post-delivery. Honestly, I would prefer vital signs more often if it was my patient. You may be a little busy. And there's another picture. And another one. Multiple births. Maybe your mom didn't get any prenatal care. Maybe she has no idea she's pregnant with 2. Her abdomen might just appear abnormally large. You might consider this a multiple birth if abdomen's really large, or if it remains large after the first baby, or if contractions continue. You're going to time the delivery of both babies and be sure to identify which one is A and which one is B, and so on. You will not use a marker or an ink pen or anything else to write on them. It's permanent, so do not write A or B or 1 or 2 or anything else on the babies. Sometimes you can get a string and lightly tie it around their wrist or something, or mark the blankets that they're in, but don't write anything on the baby. If you do tie something around the wrist, make sure it's loose enough and absolutely doesn't cut off circulation. So keep that in mind. There may be 1 or 2 placentas. Babies are usually smaller and they'll require some assistance after delivery. They'll have poor ability to conserve their body heat, immature respiratory system, and they'll need the smallest equipment that you have available. They'll also need an extra set of hands. You may find yourself taking care of 2 babies and a mom with just 2 crew members. So delivery, clamp the cord of the first baby before you deliver the second, and usually the second baby will deliver shortly after the first. Care for the baby's mother and placentas as you would a single birth. Premature infants, definition is less than 28 weeks or under 5.5 pounds. Management, keep baby warm, keep airway clear, assist ventilations as necessary, and resuscitate if necessary. Watch the umbilical cord for bleeding, use blow-by oxygen, and avoid contamination. And of course, consider diversion to the nearest hospital. Meconium. Stool released by the fetus in utero indicates possible intrauterine stress, and amniotic fluid may be greenish, yellowish, or brown, and you might anticipate ventilatory support. Fortunately, most cases can be handled with the bulb suction. If staining is noted in fluids, suction mouth and nose as soon as the head emerges, and do not stimulate the infant until thorough suctioning has been performed. Here is a meconium aspirator. You'll have 2 in each kit, and you'll need your intubation equipment, your smallest intubation equipment, a blade, a handle, 2 ET tubes, the aspirator, suction turned down to 80, and you'll see S&P 315A for the care of the neonate. I would encourage you to look these things up before you end up in that position. Meconium aspirator will be connected to the suction tubing, intubate in the usual manner. You may not visualize landmarks due to meconium. You'll quickly connect the aspirator to the ET tube and withdraw while suctioning. Try to minimize that time to less than 2 seconds. If you need to repeat it once, go ahead. Try to keep that as clean as possible and quick. So what needs to be documented? For your mom, fetal fetal heart tone prior to delivery, vital signs Q15, delivery time of the baby, delivery time of the placenta, estimated blood loss, and which medications you gave. Baby, of course, delivery time, vital signs Q15, APGAR scores, resuscitation efforts, and medications given. I would take vital signs more often than Q15. Assisting with a normal delivery, delivery procedure, cutting the umbilical cord, evaluating the infant, delivery of the placenta, initiate frontal massage, and promote uterine contraction. These are all things we pretty much have just discussed. After the delivery, you're going to rub the baby's back to stimulate. Just rub the baby kind of all over just to dry baby off, and that will help to stimulate. Don't shake the baby and don't slap its buttocks. Use blow by oxygen if the heart rate's less than 100 or persistent central cyanosis is present, and resuscitate per NRP guidelines if necessary. Your APGAR scores range from 0 to 10. 7 to 10 points is a newborn that's active and just requires routine care. 4 to 6 points, your newborn is moderately depressed, provides stimulation and oxygen, and 0 to 3 points will be a severely depressed baby. You'll provide extensive care with BVM and CPR. Excuse me. Your APGAR scoring, they have 5 areas and a score of 0, 1, or 2 in all 3 of those areas. So appearance, that's the baby's color. If at 1 minute and 4 minutes, which is actually at 5 minutes, your baby is completely blue both times, they're going to get a 0 for both. If they're kind of pinking up at 4 minutes, they'll get a 1. And if they're completely pink, then they'll get a 2. And so on down the line. Pulse, no pulse, less than 100 or over 100. Grimace, completely flat affect, or a little bit unhappy, or a lot unhappy, will get you 2 points. Activity, completely limp, will get you 0. A little bit of tone will get you 1, and moving around will get you 2. Respirations, no respirations, or weak or slow, or a strong cry will get you scored on that as well. You'll determine at 1 and at 5 minutes postpartum when possible. If you're too busy, you're too busy. You do the best you can with what you have, but you'll just try to get them as best you can. Your S&P 315A is your care of the neonate. You'll note time of delivery, follow NRP guidelines, and provide supportive care if there's no MEC, and you'll clear airway with a bulb syringe. You'll do suction the mouth and the nose. You'll use blow by oxygen if indicated. Only suction the trachea using meconium aspirator in the presence of thick meconium staining, and baby is not vigorous. Lacking a strong cry and good muscle tone. If baby is got good muscle tone, heart rate's good, and there's only a little bit of meconium, then you're then studies show that it's not really productive. It doesn't do a whole lot of good to go ahead and use the meconium aspirator if baby's already good. So you'll dry, stimulate, and reposition after suctioning. Evaluate respirations, heart rate, and color. If apneic or heart rate less than 100, begin PPV for 30 seconds. If your heart rate's less than 60, you'll go ahead and begin chest compressions. And heart rate's over 100, supportive care with blow by O2. Less than 100, positive pressure ventilation. Less than 60, you'll start compressions. You'll reevaluate the heart rate every 30 seconds. Intubate, insert the OG tube if PPV over 90 seconds. OG tube, You'll keep the baby warm, dry, wrap in a towel or blanket. And you'll keep newborn level with mother's vagina until cord is clamped. Clamp cord 6 or 8 inches away from infant's body. You'll obtain APGARs at 1 and 5 minutes. Maternal care postpartum, bleeding, place sterile pad over vaginal opening, put pressure on lacerations. If bleeding is excessive, you may need to massage the uterus or fundal massage. Encourage breastfeeding, which will help to clamp up and increase the contractions to stop the bleeding and go ahead and expel the placenta. You'll use Pitocin, 10 to 20 units in a liter of LRNS, titrate to uterine contraction under the direction of medical control only or following current protocols. If mother shows signs of shock, you will use high concentration of oxygen, which she should already be on, and volume resuscitation. You'll monitor for signs of hypovolemia and treat shock per protocol, postpartum hemorrhage. Remember, 500 cc's post-vaginal delivery is normal, and 1,000 post-C-section is normal. You may consider Pitocin 20 units in 1,000 cc's of NS or LR and maybe administered as a bolus. A second 20 units may be given in 1,000 cc's bolus. If no IV access, Pitocin 10 units IM may be given after delivery of a placenta. Frequent fundal massage and assess for clots, and if available, ice pack to perineum to reduce edema and bleeding from tears and lacerations. Side note, please remember that all Pitocin boluses must be diluted in 1,000 cc's. Do not administer IV push, and greater than 40 units is not effective, may cause water intoxication, and if bleeding continues after 40 units, you'll need to consider second-line medication. Fundal massage, only perform after delivery of placenta, will feel uncomfortable to the mom. She will not like you. Massage until the uterus feels firm, and then recheck it every 5 minutes. And what you're doing is you're stimulating the contractions to go ahead and stop bleeding and close up all the little loose wires that are gushing blood. And when those muscles contract, it kind of contracts and stops the bleeding as well. It expels everything that's left that still might be bleeding, and then it can stop bleeding on its own. So you'll place one hand immediately above the symphysis pubis, and then place the other hand on top of the fundus, the uterine fundus, and then you'll massage with both hands, like so. Okay, so all these complications, we've discussed a few of them. We will quickly run through the rest of them. Umbilical cord enters the vagina before the infant's head. The pressure of the head will occlude the blood flow. You need to, this can cause fetal asphyxia and can rapidly ensue if circulation through the cord is not reestablished and maintained until delivery. So you need to do something about it. This is a surgical emergency. You can elevate the mom's hips, knee, chest, Trendelenburg, administer oxygen, keep warm. You may have to use your hand to push the baby's head up off the cord and hold it off the cord until you get somewhere. If the cord is seen, raise the fetus off the cord. Don't push the cord back. Wrap the cord in a sterile, moist towel. Keep the cord warm and clean. And use high flow O2 on mom. Transport immediately. Do not attempt delivery. Elevating the presenting part reestablishes fetal circulation, and maintain this hand position during the rapid transport to the hospital. What if there is a nuchal cord? Well, you will gently slip the cord over the head if possible. Remember, baby's real slippery, and so it may, if it's not just pulled too taut, it may just slip right off. If it can't be slipped over the head, you'll clamp in 2 places. You'll cut between the clamps with surgical scissors. Amniotic sac intact. If use a clamp to tear the sac, release fluid. Okay. If the sac is still intact, you're just going to make sure that the sac is not blocking the baby's airway. If baby's too big or mom is too small or there's ineffective labor, we have some maneuvers we can do to help with that. Shoulder dystocia occurs when the fetal shoulders impact against the maternal symphysis. Risk factors: maternal obesity, diabetes, post-term infant. You can use McRoberts maneuver or suprapubic pressure, not on the pubic symphysis though. A large baby, small pelvic opening, turtle sign, baby might look like a turtle. To manage this, you need to have mother sit up and pull knees to her shoulders. Squatting works well. This will open up, get you a little bit more space in there. Suprapubic pressure on the shoulders. Do not push on the pelvic bone. may have to break the clavicle. I would hope not, though. But this is a McRoberts maneuver and kind of shows how you can get just a little bit extra space pulling mom's legs up, her knees to her chest. Uterine inversion. This is a true obstetric emergency, and this is when the uterus turns inside out and extends through the cervix. This is very rare, and there's a higher chance with inexperienced personnel. It can lead to profound shock. You'll always support the ABCs, supportive care, volume replacement, and rapid transport. Uterine rupture, tearing or rupture of the uterus. This is extremely painful. She will complain and will often go into shock rapidly. Abdomen will be tender and rigid, usually. Fetal heart tones will be absent. Treat for shock, give high flow oxygen, start 2 large bore IVs of normal saline, and transport rapidly. Pulmonary embolus or amniotic fluid embolism. This is a blockage of a pulmonary artery by air, blood clot, amniotic fluid, or fetal debris, or another foreign object. You're predisposed by extended periods of immobility, venous injury, hypercoagulability, pregnancy, birth control pills, trauma, or long bone fractures. This usually occurs during labor if it's going to occur to a pregnant mom or shortly thereafter. Abortion, abdominal trauma, amnio infusion, increased incidence in patients with allergies, and unpredictable and unpreventable event. Signs and symptoms include sudden dyspnea, hypotension, sharp chest pain, seizures, tachycardia, tachypnea, cough, hemoptysis, whatever, distended neck veins, and fever. There will be 2 phases. Hypoxia results from pulmonary artery vasospasm and pulmonary hypertension, elevated right ventricular pressure. Hypoxia then causes myocardial and pulmonary capillary damage and left heart failure, acute respiratory distress. Women who survive the above events may enter phase 2. Hemorrhagic phase characterized by hemorrhage, uterine atony, disseminated intravascular coagulation. Mortality and morbidity. Mortality approaches 80%. 50% die within 1 hour. 50% of survivors, phase 1, develop coagulopathy. Neonatal survival is only 70%. Treatment of amniotic fluid embolism is supportive care, ABCs, fluid resuscitation for hypotension, continuous monitoring, and anticipate ICU admission. Postpartum hemorrhage, remember we discussed this a little bit already, refers to blood loss of more than 500 milliliters during the first hour after delivery, or cesarean birth, blood loss at 1,000 to 1,200 milliliters or more. Causes can be any condition that interferes with the ability of the uterus to contract, and lacerations of the cervix, birth canal, or perineum, retained placental fragments, and disseminated intravascular coagulation. Remember, this is a description of an event and not a diagnosis. So we'll stop. Postpartum hemorrhage risk factors: overdistended uterus, multiple gestation, previous postpartum hemorrhage, abruption, placenta previa, prolonged labor, precipitous delivery, infection, excessive administration of tocolytics. Etiology, less than 24 hours, usually uterine atony, retained placenta, and products of conception. Genital tract trauma, lacerations, uterine rupture, uterine inversion, placenta, accretia, blood dyscrasias. Over 24 hours to 6 weeks would be infection, placental site subinvolution, and retained POC. Assessment would be sudden bleeding, signs and symptoms of hypovolemic shock, soft, relaxed, non-contracting uterus, and pallor. Interventions include fluid replacement, uterine massage, oxytocin if massage is ineffective. You can see S&P 315 for treatment. Oxygen, IV, may consider Foley. massage fundus, accurate eyes and nose, save pads to weigh, 1 gram equals 10 cc's, ABCs, IVs, evaluate etiology, uterine massage, rapid transport. Possible oxytocin administration. Ectopic pregnancy is an implantation of the fetus outside of the uterus. This is the leading cause of maternal death in the first trimester. Every patient in childbearing years presenting with a clinical scenario of lower abdominal or pelvic pain and vaginal bleeding should have the possibility of ectopic pregnancy considered and ruled out. This is a normal uterus and ovaries and fallopian tubes. This is an ectopic pregnancy. Predisposing factors include previous infections, pelvic inflammatory disease, previous ectopic pregnancy, previous abdominal surgeries, IUD, previous tubal ligation, ovarian cyst, or endometriosis. Signs and symptoms include severe unilateral low abdominal pain, pelvic pain, later missed period, vaginal bleeding not present in all cases, breast tenderness, nausea and vomiting. Management, of course, ABCs, scene safety. Considered a surgical emergency. Treatment in the field is only supportive. Get some IVs, oxygen going, volume replacement. Frequent assessment of vital signs, rapid transport. The only thing you can do is get her to surgical, and that's the definitive care. So, abortion or miscarriage, delivery or loss of products of conception before the 20th week of pregnancy. There's spontaneous, threatened, inevitable, and therapeutic or induced. Cramping of the uterus. Signs and symptoms include cramping of the uterus, vaginal bleeding less than 20 weeks. Care of the patient with threatened abortion is generally supportive. IV fluid, pain control, rapid transport, and emotional support. In summary, you should be able to discuss the normal changes of pregnancy, describe the assessment of their OB patient, identify and discuss a few of the most common complications, and discuss pharmacological interventions that we may see or need to use. You can discuss indications and signs of imminent delivery, basic delivery of the newborn, care of the newborn, and how we monitor mother and baby both pre-transport and en route. Thank you so much for your time, and I know that was a long one and very graphic detail, and I appreciate you guys sitting through it. And now you are ready to successfully transport even the scariest of patients. Let me know if I can answer any questions, or if you would like to further discuss any of the subjects mentioned here. You need some more pictures, or if you need some case studies. And I've actually got more monitoring strips, because that we didn't get to touch base on too much, but that is going to be a valuable skill that you'll probably use more than most of the other stuff, in fact. So I definitely have more strips. I'll be more than happy to share them, and we can sit down and figure them out. And again, I would highly encourage you to take an OB stat or a high-risk OB course, or both if you have them available to you. And just do the best you can with what you got. Familiarize yourself with your equipment and with the tools that you have at hand. And as always, I'm available for questions, and your clinical educator will be available for questions. And I just appreciate your time and appreciate you sitting through it. So, way to go. Go team. And